you know, if they need to ask a question, don't worry, I'm cool with it. No, it's not a big deal. I'd rather for you to ask it than to forget and not you know not clear something up.
All right, the floor is yours.
Okay. So let me introduce myself to you folks. Hi, my name is Ramond Caron, and I'm from South Carolina originally. That's where I'm born and raised. I am half French and half Lebanese. My mother's Lebanese, and my father was French. And went to University of South Carolina undergrad, and we're not doing too well in football, by the way, but anyway, I'm still watching. And I went to a foreign medical school. I went to the Dominican Republic, and I graduated from there, and I met my wife there and brought her back. And so I got a wife and 3 kids, and her mom and dad live with us too. So I have a lot of Dominican Republic in my house. I have a standard medical degree, you know, MD medical degree. Did my residency between the University of Minnesota and the Orlando Regional Medical Center, and which would be eventually called Arnold Palmer Hospital. I have a law degree too, so we're going to mix a little bit of medical legal law in here today too. I'm going to make a hodgepodge of different things. And the students who have been in my office before, like William, they know I would give lectures every week, and we would talk about different topics. And I try to give you an interesting viewpoint of where stuff that I've been exposed to. You know, one of the things that really was in my favor. Hello, folks. The later on's Bao, Jamie, and Nikisha. Hello, Alex. I saw him before. All right. So my one thing that's kind of interesting about my background is that I've had University of Minnesota was what they call a tertiary care center. It's one of the centers around the country. There are about 4 or 5 of them, where when everything else fails, they send you there. So it's almost like it's the last ditch effort. So death was something we saw every day. So that was a little hard to take when we would see children coming in, and you know, you were hoping that they somehow would be able to survive these cancers. So University of Minnesota was sort of like a guinea pig area for new and expanded treatments. And I'll give you an example of something I'm sure that you know about. Osteogenic sarcoma in kids tends to occur in the distal bone areas, and it was 85% mortality rate back when I was a resident, and I was a resident from 84 to 88. So it was, but now that has completely flipped to 85% survivability versus 85% mortality. So things have changed quite a bit in just a generation of physicians or practitioners. Now remember, we're all practitioners. We're practicing medicine. We learn new things every day. I've been doing it for 30 years, but do you think I know everything? No, I don't. And don't ever get cocky enough to think that you know everything, because those are the ones that fall hard, flat on their face, okay? Always be open to new ideas and opinions from other physicians, and you can absorb those opinions and they can become part of you. Now, you don't have to absorb everything. The bad habits, you leave them alone. And we're going to talk about that a little bit later on. For I'd say at least 25 years, I've been part of what they call the prosecuting team of the state of Florida for the Department of Health, where we prosecute people who do bad things. And there are doctors and practitioners of all sorts, including PAs, that do bad things. We're all human beings. So remember, what we do is a privilege, and privileges can be lost. So I want you to understand that I just yesterday entered a stripping of license of a physician who had done an exam on a 14-year-old female without using gloves. a private area of her body. So I demanded that he be stripped of his license. Now, whether they strip him or not, probably won't. They'll probably smack him and fine him and so forth, and this kind of thing. So we're going to touch on that a little bit later once we talk about, I'm going to use this as common. We're going to go over some very common diseases in pediatrics so you'll know what really matters. And like William, when William was in my office, I tried to teach everybody what really means something and what doesn't. In other words, if you see a lab and it's abnormal, it doesn't necessarily mean that you need to freak out and have a heart attack. You know, big deal sometimes, okay? And you need to know exactly what is pertinent and what's not pertinent, okay? Ready? So I did a year of emergency medicine. That's another part of my background. So I got a lot of experience there. That was a great thing. I'm so happy that I did that year of ER medicine because I learned a lot. Nod your head if you've already done your ER rotation. Okay, so most of y'all have already done it or are either doing it now. So, and I hope you learned a lot during the ER rotation because you hopefully see a lot of stuff. You know, you learn how to suture, and it comes in handy. My dog, my wife's dog, had a big old gigantic lipoma on his arm, which is the size of a plum, stick it out, and I couldn't get a veterinarian to take the thing off. They were like, "Oh, it's an old dog, let him die, he'll be okay." And I'm like, "No, I'm not going to do that." I got tired of looking at it, so I did it myself. And the dog's doing fine. I'll probably take the stitches out tomorrow. But you know, that's how you got in your practice right now of medicine. You guys are so much more advanced than my generation was at your level. And I say that very honestly. What you're exposed to in the hospitals and with clinicians is double the proficiency of what we were exposed to when we were residents. Okay? You're exposed to the MRIs and all this kind. There was no MRI when I was a resident in the mid 80s. It was just CT scans, and they weren't that good. Okay, so see the things that you're exposed to right now. You're light years away from what we did. We picked up on this stuff as it came along. Now we continue to have our board certifications, which in pediatrics I have to do that every. Every 10 years now. So I'm on my 4th time and I'm almost 70 years old. So this will be my last hoorah for as far as board certification goes. I'll have to take this last one and then that'll be it. I won't have to worry about it anymore. But it is good for you when you take your certifications. It kind of keeps you up to date, kind of forces you in the corner a little bit and makes you make sure that you understand things the way you're supposed to. Okay? All righty? Let me see if I left anything out of my background. Yeah, that's about all that's important. So I've done 30 years of pediatrics too. And by reviewing other physicians, well, another thing is I've been on almost every insurance company physician review panels where doctors do bad things, or not so much bad things, where things go wrong. It doesn't necessarily mean that you're gonna do something bad. Things go wrong and then you get blamed for it. Now remember, as practitioners, you're just as good as you are being unsued. So we have to protect ourselves from not being sued, right? And that's an extremely important thing. I don't know how much have they been talking to you about this so far? About how you stay unsued? Has anybody said anything to you about that? No, I don't see anybody moving their head. So it must mean that unless William, I talked to William about it, but unless you've heard it from a lawyer, which I am a lawyer, I just never took the bar. I don't practice law, but I have the degree. And I remember in school, it was very, very important. Once I learned about it, I thought, golly, you know, we could get sued and then all of a sudden we're out of the business. Because you can't get a job when you got lawsuits on your back. Right? They're going to be afraid something's wrong with you, even though maybe there was nothing wrong with you and it wasn't your fault. Okay? I'm going to do the quick scenario before we get into the medical part. And while it's on my mind, I'm going to give you a little quickie story. And then I want you to kind of mentally answer this question. Okay? And this is going to show you how vulnerable you are and how you need to think medical. When you're thinking legally, medically, you need to also be thinking medical legally. Okay? Are you with me? Anybody need a coffee break? Go grab a cup of coffee first before we start? No? Okay. Okay. All righty. So for that later, Alex and Brian and Jamie, hello. I'm Dr. Caron. How you doing? All right. So now I want to throw a scenario at you. So now, William, you got to be quiet because you already know this. All right. All right. So let's pretend for a minute that you were working in my office and we worked our butt off today. Hey, Mike Kim, how you doing? And we're working in my office and you worked your butt off today, or you're working in any office. And at the end of the day, your husband was going to, or your boyfriend to be was going to take you to the Bahamas for the weekend. So you want to get the hell out of there, right? 5 o'clock comes, you're ready to rock and roll out the door. Hello, Tatiana and Liz. And so as you're getting ready to leave the door, you get a phone call. And it's from a lady you know very well. You take care of her kids. She got a bunch of kids. You took care of them. And you diagnose one of these kids with a heart murmur. And so she calls you. She says, look, my little boy, Johnny, who you diagnosed with a heart murmur, is going to have surgery tomorrow. And the doctor never, the pediatric surgeon, pediatric cardiologist you sent me to always said that if you ever have a dental procedure that he needs to have prophylaxis. Now, that's not necessarily the standard anymore, but you get older physicians who've been doing it all their life, they're not going to change. They're going to continually to give the prophylaxis like me. We've done it for 30 years, and it works. Why are we going to change when it's just a dose of amoxicillin? All right, so let's say she's across the street from your office at a gas station, and she says, can I please come and get a script for the amoxicillin? And you go grab the chart real quick, and you look at the chart, and you see that it is true. The cardiologist sent you a letter, said the kid had a VSD, and you should probably just give 1,000 milligrams of the amoxicillin antibiotic 30 minutes prior. 30 minutes prior to the dental procedure. Okay, so the lady says, I'm right across the street, he's with me, and I can run over to your office if you need to document things, because she said, I'm a medical assistant, and I know how important it is. Put this on Never Never Land, hopefully. I'll turn the volume down. So anyway, you're sort of stuck with a dilemma here, right? You know the lady, you're the one that diagnosed the heart murmur. You got a letter in your chart that says to give a gram of the medicine prior to the procedure. However, the lady, the dentist never did send her a script for the 1,000 milligrams. And she's asking you, would you please give her the script? Hey, Kayla and Samantha and Tatiana. Okay, so now, I guess I want you all to think about it. There got to be some pros and there got to be some cons to doing this. Can anybody tell me real quick what would be a pro to doing this? What would be a reason to do it? To give the lady the script, even though you are not the dentist. You are a practitioner, so you are allowed to write a prescription, right? And if the lady wants to bring her kid right over to you, then she's right across the street. So tell me somebody, that would be a reason to do it. What would be a reason to go ahead and do this? Well, I guess maybe one reason would be that the kid would get his teeth fixed. He's having a dental procedure done at the hospital. So it's very, very important to get this thing done, right? And I left out one part. She's a maid. She works in a hotel. And for her to lose a day wages, it would be devastating to her. And this is actually a true story. I had seen the kid when she was a younger child. So pros would be, let's say you're helping the lady to get this done. It's a moral thing to do to get the kid's teeth fixed. He could get an abscess. If he doesn't get the thing fixed, teeth pulled or tooth pulled or whatever the heck it is, he may get an abscess and then have worse problems, right? Okay? So the good part about it would be the feely good stuff, right? Okay. Yeah, are we in agreement? Shake heads, yes or no? Okay. All right. And what would be a downside to this? Anybody got any thoughts? What could go wrong? Can you think of anything that would go wrong, maybe? Do I have to undo your voice thing, or do y'all have control of that?
No, they have control of it.
So they do. Okay.
Yeah.
So
And please, if he's
anybody,
asking for interaction, please give it to him.
yeah. What would just throw a downside at me? It doesn't matter. Don't worry about making yourself look dumb. I would have given the wrong answer anyway myself. So. What could
allergic
go wrong?
reaction to the medication.
Could you think of anything that could go wrong?
Allergic reaction to the medication?
Yeah, allergic reaction to a medication. But in the chart now, he's already had amoxil, so it's not a big deal. But that's a good answer. All right. What else could be? You know. Well, what if something went wrong in the surgery? Okay. David Levy's asking a question. Did the cardiologist clear him? Yes, he did. The cardiologist has sent her, she has in her chart a letter from the cardiologist, and it said that it's okay to do a dental procedure on him. It's not a big deal, and that all you have to do is give 1,000 grams of amoxicillin 30 minutes prior to surgery. And that's what she's wanting from you. She's wanting you to give her that 1,000 milligrams of amoxicillin.
What if the dentist already had something planned?
What if what, huh?
What if the dentist already had something planned and now you're just interjecting? Well,
again, you're getting very warm, okay? You're interjecting, in a sense, in a surgeon's procedure. Or not so much interjecting, but you are interjecting, I guess, is the word for it. You're putting yourself into a surgeon's chart, medical legally. You become part of that chart, even though you're doing a good thing, right? You're doing a good thing, Riley. If you gave that script to that lady to help that lady, right, Bao? It would make you feel good. You're helping her. Now, see, we can't do feel-good things in medicine all the time. We have to do them within parameters. Okay? So, what really happened with this child was the kid went to surgery the next day. The doctor did give the prescription to the person. Okay? The dentist pulled 8 teeth. It was a retarded child. So there was a young lady, she was 16 years old. And I had actually seen her when she was younger. So she had a dental surgery done at Florida Hospital. They pulled the guy pulled 8 teeth, and the child died of pancarditis 3 days later. So strep viridans went down through some of those holes that were made in the mouth into the portal system of the excuse me, of the lymphatics, retrograded its way back up to the heart, colonized the heart went into failure, kid dies. So what do you think the first thing the parent does is? Morgan and Morgan, right? Right? She starts screaming foul play. Does she back you up that you did her a favor and wrote the script for her? How many of you think that she backs you up? Don't ever make that mistake. She don't give a shit about you, anymore, because there's $1 million or $2 million hanging in the wind, and you are forgotten. She don't remember your name, Namita, anymore, even though she loved you a month ago, right? And you took care of her kids all that time, for years, let's say. Didn't even know who you are anymore. All she sees is a $sign above your head. And that's the way it ends up being. So please take my advice. The worst thing that happened was the dentist went bare. In other words, the dentist did not have insurance. You can do that in the state of Florida. If you put $250,000 in a trust fund, you can go bare. They call it going bare. And the hospitals allow you to have privileges too by doing that. So the dentist goes bare. The little pediatrician had $1 million life insurance policy. Guess who became the target? Right? Little pediatrician with $1 million life insurance policy. They loved her. So she went down. Okay. She was found guilty of prescribing medications for a patient she had never seen or had not seen for that particular issue, which was surgery. She gave the prophylaxis. She should have bowed out and just said, and you can bow out in different ways. You can bow out by saying, you know, guys, I would love to help you so much. You know, I love your children, but my insurance will not allow me to get involved in surgeries. Okay? And that's how you bow out. If she gets mad at you and leaves and goes to another office, guess what? C'est la vie. There's other patients that will be coming right behind her. Okay? So we can only go so far by being the Good Samaritan. The doctor, she didn't lose her privileges, but she was fined. I think they fined her $50,000, put her on probation. She had to do all kinds of risk management stuff and so forth and so forth. Plus, you've got a mark against you on your record that says that you have been sued. Okay, and whenever you apply for jobs or apply to be privileged, when you're seeing patients, you have to be approved by these insurance companies. When you're a practitioner and you see United Healthcare patients, you have to be approved by United Healthcare or you can't see their patients. So see, now you've got to explain to 25 insurance companies why you were sued. So do you see how much of a you don't need this kind of a nightmare in your life, right? I'm sure you've all had either bad boyfriends or bad girlfriends, right? Well, this is like one of those on steroids because it never goes away. It stays on your records forever and forever, and it's a bad deal. So please take my advice. Don't ever get involved in anybody else's chart. They're big boys and big girls. They can buckle up their own britches. Let them do their own thing. And then you'll stay out of trouble. You won't have those types of issues. And that doctor who did that, boy, she did she not help that lady that day. Okay, the state could have given a toot what that lady did for the other lady at all. It didn't matter. Okay, it didn't save her from being sanctioned. And the Board of Medicine is not something you want to go in front of. It really isn't. Okay, I was appointed by Governor Jeb Bush. He appointed me to the Agency for Healthcare Board, and they were under us. We used to have to monitor them, and they would do all kinds of crap to people that was not fair. And we would have to tell them, it was like the Supreme Court. We'd have to say, hey, look, guys, you've got to go back and look at this. This was not fair. We don't think that this justifies this doctor having lost his license. He should have maybe been sanctioned and maybe sent a letter of concern and maybe didn't make him do this or her do this or do that, but not take their license away. So these boards sometimes, they're kind of ruthless. You don't want to be in front of these people. I don't want to be in front of these people. Okay? Okay? Are we all de acuerdo? Like they said in The Godfather, right? De acuerdo? Okay. So now we're going to jump off to some topics here. I got another hour and a half to go to tell you different things. So I think I'm just going to jump from one ramus to the other and talk about things that are kind of important. And I was, excuse me, this morning I was thinking about cardiology. Anybody wanting to go into cardiology? So David's thinking about doing that. That's good.
I do. Yep.
Okay.
Yeah, that's my practice.
Cardiology is interesting. I almost did that myself. I thought about it. But there was some things that were a little too technical for me. But I almost did it because I thought it's fascinating. And it works. I mean, you fix one thing, it works. It fixes it, and it was just really nice. But one of the things that bothers me about what we do as practitioners every day is, you remember those old things that kind of are a pain in the ass called books, right? Textbooks. And sometimes textbooks are thought to be Bibles of certain areas, like Sabiston is your surgery, Harrison is the internal medicine book, and there are a couple of peds ones out there, and different things call certain books Bibles. Now, some of these Bibles will make statements, okay? And I'm going to give you one of the statements that it makes about cardiology, which is that in children, if you have a murmur that's less than a grade 2, it's not a big deal. You can follow it. Okay? All right, now that is only partially true. Because I had a patient one time that came to me, she was 4 years old. She had a grade, excuse me, I've got a little cough here today, and I'm always doing this anyway. But anyway, she comes to me and she had a grade 1 murmur, barely audible. In the history, I asked the mother if there was anything wrong with the kid. Did the kid have any particular type of history? And she told me that the child had been admitted to the hospital when it was a baby, and it had been diagnosed with viral myocarditis. And I thought, that's interesting. Well, we've got a murmur, and nobody else has picked up on it. And the book says it's okay, right? That under grade 2 don't make a big deal out of it. Okay? So what do I do? Being Mr. Worry About Everything, which I think you should be, or Miss Worry About Everything, I send the child to the cardiologist. And the cardiologist called me back and said, I knew him, he's retired now. He said, Ray, he said, this kid's got the biggest heart I ever saw. I said, ooh, that ain't good. I said, what do you think happened? He said, I think the kid had viral myocarditis with cardiomyopathy. The mother never took the kid back to the cardiologist. She swears the cardiologist said never, that you don't have to come back. But I can't imagine a kid being on the ICU and being told never come back for follow-up. I didn't believe it. Right? Do you believe it? Yeah, I wouldn't believe that either. So anyway, the kid was so sick, the child was put on the cardiac transplant list. And actually got better and was taken off the cardiac transplant list a few years later, and would have gotten so much better that they allowed her to start playing basketball at the Boys and Girls Club. Okay? So she dropped dead playing basketball. And so what good did that book do? What good would that book have done telling you that under grade 2 murmurs, don't worry about them? Well, this kid's heart was so sick that it didn't have the strength to even produce a murmur. She actually did have a little VSD, and that's where the murmur came from. So you see how far the books can take you? Sometimes you have to interject with your common sense and be a little afraid of certain things. And I'm going to try to touch on most of those be afraid of things. Let me say hello to some other folks that have jumped on. Anissa, Emily, Laura, Stephanie, Ashley, Andrew. Hey, Andrew. And Melissa, Kelsey, Felicia, Kayla, Alexander, Tatiana, Samantha. I already saw Nikisha. Didn't I already see you, Nikisha? I think I did, didn't I? Yeah. Brian. Okay. So I just want to say hello to everybody, whoever's jumping on. So what would have happened if you had sent this kid out and she had a grade 1 murmur and she dropped dead about a year later and you were the last one to see her? They're going to start looking at your chart, trying to figure out, did you do something wrong so they can sue you? Okay? That's what the nurses for Morgan are going to do. And they take courses in this stuff, how to spot, to look for things that we leave out. They're prepared for anything and every possible thing that you could do wrong. They look for it. They go right to the page. And they'll find your last exam and they'll listen to that cardiac exam. And and do you think that that pediatric textbook is going to save you in court? How many say yes? Does anybody say yes? Please don't say yes, because it won't. Courts are juries with emotion. Remember that. It's all emotion. They can stir that jury up in 2 seconds full of mothers, and all of them are going to be looking at you with nothing but hatred. Because if that was their kid, they'd be ready to come off that. They'd be coming over that wall that separates you two guys, and they'd be choking you to death. So remember, textbooks are that. For our textbooks, they're guides. That's what they are. They're not Bibles. We're going to talk about that when we get to urology here in a few minutes, that there are a lot of things that you need to do on your own. So with heart murmurs, I told everybody, I like to document my heart murmurs. So when I hear a heart murmur in a baby especially, they go to the cardiologist, let them do a sonogram. See, the cardiologist would love you because that's how they make a living, right? By doing sonograms. So they can do their little thing, make sure that the heart is good, and then it protects everybody. It protects the baby, and it protects you guys, okay? The dog on the screen is a black thing on my face there. Now, Wednesday, be quiet. That's one of those 8 dogs in my house right now. So, one of the things too, when you're dealing with children with cardiology, is that their femoral pulses are unbelievably important. Okay, don't let a kid go out of your office with a femoral pulse that's weak or absent. You pick up the phone, you get on the phone with the cardiologist, you call them and tell them you got even a weak femoral pulse could be a tragedy waiting to happen within the next 24 hours. So you get on the phone, you call the cardiologist, and you cater to people, they cater to you, right? You refer to certain people, they're going to hear your phone call come in, they're going to take your phone call, and they're going to see that patient the next day, or even maybe that day, if they're concerned. An absent femoral pulse, a pediatric cardiologist is going to see that child the same day. They're going to do a sonogram, they're going to make sure that that aorta is not pinched somewhere as it descended, right? And with a pinched aorta, you're going to have renal issues because you're not going to be getting good perfusion to the kidneys. So the kidneys don't develop. Now you're going to start developing hypertension because the kidneys are going to think that the blood pressure is low, and they're going to start producing renin and angiotensin, right? And they're going to shoot the blood pressure up. So you're going to get pre-ductal or a compression of the aorta, or where the defect is. Everything's going to be hypertensive above that area. And you can blow blood vessels. They'll blow in the brain especially, and you'll have aneurysms. Okay? So those are 2 things to be extremely careful about: murmurs in kids and femoral pulses. And remember that none of you are cardiologists, and I'm not either. And I don't play cardiology, because the heart is the center of the body. You can't deal with that. Without a good functioning heart, you're in big trouble. Okay? The heart and the lungs. Of course, the kidneys too, but I'm just saying, your heart is the meat grinder here that keeps everything going. Anybody? So I want you to tell me if you have a question about cardiology. Anything worry you? Are you scared about anything?
So Dr. Caron, cardiology is actually my practice area.
Oh, great.
Yeah, and I will confirm the vast majority of what you said there. Pretty much anybody who walks in our door, they're all getting an EKG.
Good.
And if they have any cardiac complaint at all, whether it's hypertension, murmur, anything else, they're getting an echo too.
Gotcha.
If it is, things like stress tests, cardiac CTs, the rest of that is all kind of determined on what their presenting issues are, but pretty much everybody is getting at least an EKG and an echo. You're right,
Excellent.
absolutely on that.
Excellent. And with this sports EKG stuff too, these kids that play sports, you've got to make sure that you do a cardiogram on these kids before they hit the sports field. Remember, we all have to practice standard of care. Standard of care in our community now is a EKG, a pre-sports EKG. You take out those cardiomyopathy kids, and you take them out of the culture, and then their survival rates are much higher.
Yeah, and I will tell you.
Care.
Yeah, and I will tell you, please also set your patients up to be aware that testing might happen. I can't tell you how often that a patient will get sent to us. It's probably nothing. They probably won't need to do any testing.
Right.
And they come to us with a murmur or something else, and it's like, we have to do testing, and then they're furious with us because they were told by their referring provider that, oh, it's probably nothing. They probably won't even need to test, and then they're mad at us when we have to do it. So
we do that.
Prepare them for that.
We do that. I tell them if anything goes wrong with the EKG, they may end up having a sonogram. And so that kind of prepares them so they won't get ticked off. Because sometimes the resistance used to be big time to getting these EKGs. I've been cussed out before and told, called some fancy words. But I'm sorry, I'm not going to back down, and then something goes wrong with the kid, and then it's my fault. Then Morgan and Morgan are beating on my door. Okay? So we got to stick to standard of care. And if they get mad at you, so what? Who cares? There'll be another patient walking in the door when they walk out. Okay? You don't let them rule your life. You're the practitioner. You're the one that signs the papers. You have that power. Okay? So use it. Don't go power hungry, of course, but I'm just saying, this is something that you can use, and it's for the betterment of the patient. There's no doubt about it. Anybody have any thoughts about cardiac? Most hypertension in older adults and maybe even older kids would be cardiac in origin, whereas the little ones usually have renal artery stenosis, so that the origin of their blood pressure would hypertension would be renal in origin. Okay, so in one area you refer to a cardiologist, in the other age group you refer them to a nephrologist. Okay, so anybody got any questions? Anything you feel uncomfortable about? Okay, all right. Well, let's jump off to nephrology and to neurology. Urology. Okay. Let's see here. How would I start? I guess we could start off with a patient that I had last 2 weeks ago. Was anybody here with me with that kid that had the nephrotic syndrome? Somebody made a noise. Okay, I don't know who that was. I had a kid that came in for a routine physical, and I've known him since the day he was born. Emily's there. Yeah, Emily was there. That's right. Hey, Emily. I didn't see you first time around. So, Emily, guess what happened to this kid? I don't know if you knew it or not, but he ended up having a genetic renal disorder. What happened was we were in the room, we're checking him, and I looked down at his feet, and I noticed his feet are gigantoid. And they thought that he had sprained his ankle or something, sprained his foot, and that's why his feet were swollen. And then Emily and I were going, oh boy, that's some nephrotic syndrome or something. You think, first thing I thought of was nephrotic syndrome. So we send him straight to the nephrologist immediately, and they put him in the ICU. He was hypertensive too. And after they worked him up, he was spilling 14 grams of protein in his urine when he went into the ICU. And when they took him out of the ICU, they got him to where he was spilling only 4 grams of protein. So they had improved his kidney situation immensely in the short period of time he was there. And now he's doing really well. I saw him about 2 days ago. His feet are still kind of puffy looking, I would have put him on some pressure socks to get that puffiness down, but of course, let them do what they want to do. That's fine. They say that he has a genetic kidney disease. He was born with a weirdo. They hadn't quite figured it out yet, but it was done at Nemours Hospital, so they had the genetics people on top of him. They think he's going to have this kidney issue the rest of his life. He will be a kid that spills protein, okay, because of his genetic condition. And he'll have to take medications, basically, whatever is going on. If he becomes acidotic or not acidotic or whatever, they'll correct it with medications. Okay. Now that brings us on to another issue called proteinuria. I told you I review charts, don't I, for the state for things that go wrong with doctors, right? All right. One of the biggest things that goes wrong with doctors is they don't follow up on abnormal labs. So please don't be one of those doctors that does not follow up on an abnormal lab, because protein and blood are two of the things that when you have hematuria or proteinuria, you need to follow them until that disappears. Or if you don't want to do that, that's okay. Just refer them to a nephrologist or a hematologist and let them do the follow. That's fine. But they have to be followed. You will get blamed for anything down the road that is related to proteinuria or hematuria. I promise you. Those nurses from Morgan will find that lab you did not do a follow-up on, even if it was 10 years ago, and they'll convince the jury that you're responsible, even though you're not responsible. And even though when it comes to the pediatric reviewer like myself, I'll say it has nothing to do with it. Rapid onset glomerulonephritis could not have occurred 10 years ago. It's impossible. But a jury will say it did because it's too coincidental that it's the kidneys 10 years later that you had a problem with. But had you followed that urine, and then the proteinuria or hematuria or both would have disappeared, people understand that. It went away. What are you supposed to do? Do a laparotomy on the kid because he all of a sudden his protein has disappeared? You know, that's not something that we do. So juries are reasonable. Okay, lawyers are not. Lawyers feel as though if anything went wrong, the practitioner's at fault. We're at fault. God doesn't do anything. Okay? Or doesn't allow things. We're guilty. So whenever you have proteinuria, you follow it till the proteinuria disappears. And then most of the nephrologists will tell you they're not worried about proteinuria 2 days later. They're worried about proteinuria 2 weeks from now to see if it persists. So when you order the repeat in a couple of weeks. And have your ladies in the office follow up on it if they don't do it, okay? And sometimes what you need, this is so important, the hematurias, the proteinurias, the cardiac follow-ups, that if they don't do it, you call the nephrologist, urologist, cardiologist, and you make an appointment for that lady, the mother. And you advise her and document it in the chart. We made an appointment with you with the cardiologist or nephrologist or urologist. And if they don't follow, or the asthma doctor, if they don't follow up on it, guess what you just did? You just saved yourself. You may not have saved the child if you get a slack mother, which there are those, unfortunately. It's very sad. I've had kids die because of slack mothers. Probably doing drugs and smoking marijuana out of their brains and not taking the kid in to get checked. It's very sad. Okay? But you need to protect yourself because they'll come after you and that you'll be the culprit. You're the bad guy. All right? Am I scaring you a little bit? I hope I am. Because if you're alerted to these things, at least you're not going to make these mistakes. Okay? I'm trying to look at each one of you sometime or other. I don't know if you can see me doing that, but I want you to understand that it's good to be a little afraid in medicine, that we don't get nonchalant. Okay? I've done this for 30 years. The first 2 years I was out, I was sued twice. I mean, the first year of practice, I was sued twice. And I thought, what in the hell am I doing wrong? I sat down and I did a self-examination. of my brain. I said, okay, what are you doing wrong, buddy? You got 3 kids and you still spent all these years in school and now you're going to be working at McDonald's. And I thought, okay, what I'm doing is I'm taking ER call. And that's where those 2 cases came from. Because I was trying to make extra money and do an ER call, I was subjecting myself to exposing myself legally to different things. Because when somebody goes in the ER and they die, a lot of times they just blanket sue. They sue everybody's name on the chart. And then they'll drop you one by one as they feel as though you've done nothing wrong. So I quit doing ER call. I got, actually, by the graces of God, I got out of both of those cases. With no bad marks against me. But I learned my lesson big time. I ain't taking chances. You know, I'll do my medicine and I'll do what I'm supposed to do. And I've been in the hairiest situations you've ever seen in your life. In C-sections, gunshot wounds, stab wounds to the uterus. I've been in some hairy situations. But I didn't ask for them. They came to me because I was on, you know, I had to do those things. And I took care of them and then things worked out and they did fine. But I was out there doing extra stuff, trying to make extra money, and it got me in trouble. So you got to remember too, one of the things we do in medicine, you've got to either, if you have thick skin or thin skin, you've got to pick and choose your profession depending on, you know, if you go into orthopedic surgery or neurosurgery or trauma surgery, you're going to get sued. So you got to be ready for that. If you have thin skin and that would bother you, or you want to have children and you want to have your family first, and you don't want to have this, you don't want to not sleep at nighttime sometimes, then you best go into dermatology or go into something primary care. Pediatrics is a low suit profession too. Go into something where you're not going to be sued all the time. Okay? De acuerdo? All right? All right. So where was I when I got off on that tangent here? Let's see. We were talking about proteinuria. Okay. So anyway, with the proteinuria stuff, be very careful. Okay. One thing I want you to know, does everybody realize why they always ask you to do a first morning urine? You remember that one, William? We talked about that. Emily? Well, I don't think I've talked to, yeah, I did talk to that with Emily with that. You always hear people say, oh, we want a first morning urine. Well, what the heck? What's the difference with a midday urine or a nighttime urine or 4 a.m. urine? What's the big deal? Right? Well, here's the big deal. The big deal is that during the daytime, you are walking around and gravity is working on your kidneys and pulling protein through your kidneys. Okay? It's pulling those large molecules through the glomerular apparatus, it's pulling them south. So you're going to have more protein in your urine during the day when you're up walking around and going crazy in the hospital or in the doctor's office or wherever you're working. You know, you're walking all over the place and those kidneys are getting boom, 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 just like a basketball player. All right. So you're going to, let's say you go to a doctor's office at 5 o'clock and you did your annual checkup and they told you to get a urine sample. Well, the urine sample shows up with proteinuria. And then they tell you to come back in the morning and give them a first morning urine, and there is no protein. So what has happened is when you're sleeping at nighttime, right? I hope most of you sleep horizontally, right? Okay. I had one person one time told me they did sleep vertically because they had a lung condition. They had to sit up and sleep at nighttime, but most of us sleep this way. All right. So what happens? You lose that force on your kidneys. It's just not pulling. It's not pulling south anymore. It's pulling west or north, or it is pulling south, but it's pulling against the back wall of the kidney and not down the urethral canal to the ureteral canal to the bladder and urethra. So you lose that gravitational force at nighttime. Therefore, you don't have the protein in the urine that you had earlier. And that's called orthostatic proteinuria. It's positional. Okay? So now in the future, when somebody asks you that question, you'll be able to answer it. Okay? Because I never did learn that in my residency. Nobody ever taught us that. And I did an entire 6 weeks of kidney transplant rotation. And I was never told that. Either they just think you're supposed to know it and they never tell you or something. I don't know. But anyway, now I'm telling you, right? So you'll know it in case anybody ever throws that in your face. Okay? All right, let's jump off something here. We'll go to endocrinology real quick. Here, let's see. endocrine. Most of what you would see endocrine-wise would be a couple of things, actually. You were going to see kids that have maybe low growth hormone, where they didn't grow too tall. I don't know whoever here is 5 feet tall, but sometimes it's not, even if your parents are short, that doesn't mean sometimes that you may have had a growth hormone deficiency. A lot of the preemie babies that we end up seeing, a lot of those kids, they give them growth hormone now to make them grow bigger, and they do. They respond to the growth hormone. So just because my grandmother was probably 4 feet 9 inches tall, and I am 6'3". I used to probably be about 6'4". You start crunching when you get older. Your vertebrae start kind of crunch a little bit. So I used to be 6'4", but not anymore. But all me and I'm one of 5 brothers. We're all above 6 feet tall. So the gene, we did not inherit that gene from my grandmother. We could have inherited that gene from her. And if we did, we probably would have responded to growth hormone, because we had a dad, my grandfather, who I never knew in my life, was probably around 7 feet tall. Because I saw a picture of him in the 1930s where he's standing up next to one of those old-timey gas pumps. Y'all seen pictures of those where they have the glass at the top? They had the gas in a glass container so they could look at the gas before they pumped it to make sure it didn't have debris in it. That's why they had the glass at the top. And he was standing next to one of those. He owned a garage at one time, and he was standing next to the pump, and he was as tall as the pump. And I thought, wow, this guy's tall, lanky, skinny, tall guy. I wish I took the skinny part from him, but I didn't. And he dropped dead in a shoe factory at around 40 years of age, smoking those little old teeny. You ever seen all these old movies, the black and white movies where Clark Gable they're all smoking these little teeny cigarettes, right, with no filters on them, right? You can imagine what that does for your heart. Not good things. All right. So anyway, he dropped dead. So he was tall, lanky, had long fingers, long arms. Arms went down to his knees almost. So what do you think he had? Anybody got a thought?
Marfan.
Marfans. He sure did, I bet you. So I've been checked for Marfans as the years went by. When I was a resident at the University of Minnesota, they did a sonogram on me and they saw nothing. We didn't do the genetic testing, but we did do the rest of it, did sonogram and everything. And I've had a bunch of sonograms since then. But when I was a resident, I had a sonogram done by one of the fellows, and I didn't have anything. So, and none of my brothers have it either. We're all tall. We were all at one time tall and lanky. So we inherited some of the phenotypic characteristics of the Marfan, but we didn't inherit the cardiac part. We inherited I don't know if I have a high arch palate or not. I don't have any striae, so that's a good thing. I'm glad of that. But I do have the long arms and the long fingers and all that kind of stuff. So anyway, going back to growth hormone, when you ever think about a kid, refer them to the endocrinologist, let them do their job, because it may be that they respond to the growth hormone, okay, and you get a boost out of it. Now, one of the other problems that we have is the exact opposite, where we have obese kids. The obesity is, I'm telling you, it's just something that it's just rampant. It's almost every kid you see, especially after coming out of this most recent issue, coronavirus thing, where kids have been sitting at home. And I gained weight too. I gained about 12 pounds of this coronavirus. So I'm swimming every other night now, and I'm trying to work that off. When you get old like me, see, it's really hard to work your weight off. So don't let that weight creep up on you, because we get older, it's harder to get it off. But with these kids, you send them in, and you get there, you send them into the endocrinology folks and let them do a good workup on them and see if they have some endocrine deficiencies. And let them you can order the labs and let them go see them. And one of the good things too, when you get to the endocrinologist, they usually have programs, weight loss programs that they have set up, and you can get these kids plugged into a weight loss program. Sometimes as a practitioner, if we order somebody to go in a weight loss program, the insurance will deny it. But if you do it through the specialist, they can get certain medications approved and get certain treatments approved that we can't. Because they love to deny us, because they think that we're not going to come after them, and to be yelling and writing letters and screaming. Whereas the endocrinologist or the subspecialty people, they will do that. They'll go after these people, which is what they should be. Because if a kid needs something, we don't need to overdo medicine and waste money. But when somebody needs something, that's what we're here for. We have to be the in-between specialists and insurance companies, or the patient and insurance company. And if we have to be an advocate for those people, if they need something. If they need it, they should get it. How would we like to be put in that position and we need something, and just because an insurance company said no, everybody drops the ball and you end up suffering for something? That's not fair, right? So anyway, you'll see that most of the time when these kids are overweight, they can have the acanthosis nigricans. I'm sure you've all seen that, pictures of that, or either seen it. It's very prevalent in the children, and they don't have to have dark skin to have acanthosis. The lighter skinned kids will get it too. What happens most of the time is that in the workup, you do an insulin level and do a hemoglobin A1C. And usually most of the endocrinologists will allow the insulin level to go up, which is going to, if they have acanthosis, they're going to have hyperinsulinemia, okay? That's just part of it. They don't really treat them with metformin until the A1C starts to go out and become abnormal. They'll follow the A1C before they'll follow the insulin levels. So you could have an insulin level of 70 and the A1C is normal, and they won't start them on metformin. Excuse me. Now, metformin has some issues. It can cause kidney disease. And I have had diabetes type 2 for probably 15 years now. So I was taking those oral medications, and they damaged my kidneys. That Jardiance you see on TV, Trulicity, I was on that for a while, and it made my glomerular filtration rate go down to about 60. So I hang right now. I take an injected insulin, and I'm working real hard to get the weight off so that I can just maybe hopefully get rid of this stuff. I want to deal with it. And I did have cancer the last couple of years, and I was on chemotherapy and radiation. So that set me back. It really did set me back weight-wise, because when you take some of these chemotherapeutic agents, you just blow up like a balloon. You can't help it. One day you're 110 pounds, the next day you're 120. So it's just, that's the way the animal is, and there's not much you can do about it. So let's see here. What else is on the list? Orthopedics. I guess when you're seeing children, the orthopedic issues that you'll tend to see are bow-legged kids, okay? And that's one of the things that we see constantly, are children that have bowed legs. You're going to be shocked at when you send kids to the orthopedic people, and their legs look like a bow and arrow, from a bow and arrow, and they'll send them back to you and tell you, "Oh, don't worry about it. They'll grow out. They'll outgrow it." And I have been actually shocked that they would do. This kid one time had legs that were like this, and it just scared me when I saw them. And I sent the kid to the ortho guy, who was a great ortho guy, knows his stuff, and he told me that let it go. He'll outgrow it. Now, it is important to have these children followed by an ortho person. Number one, because it puts a buffer between you and the patient. Those specialists that we use, they are buffers to help protect you too. They protect the child, but they'll protect you against a parent that does not follow up. We're going to talk about asthma in a minute. You need that buffer. If they say, "Oh, I can't tell you how many charts I've reviewed where there gets to be a he said, she said." Oh, no, they didn't tell me I had to follow up with anybody. But if you have a subspecialist that told them to follow up with them and they didn't do it, it's much harder for them to argue that case. It doesn't fly. But with the pediatrician or the practitioner, you know, it's a he said, she said. They'll start arguing. They'll argue till you're blue in the face. That, oh, they never told me I needed to follow up because my kid had sickle cell disease and is dead now. That happened. Sickle cell disease, the mother swore on a Bible that no doctor ever told her to give the kid penicillin prophylaxis, even though they wrote the script and gave her 12 refills. The doctor made the mistake of not sending the kid to an infectious disease doctor, right? Or an immunologist or someone. Okay? I'm seeing a note here. Yep, you're absolutely right. If you don't chart it, it didn't happen. Okay? And that gives you an extra buffer. I can't stress that enough to you. To use your subspecialty. Don't worry about saving insurance companies. Oh, I see a new person, Tia. Hey, Tia. Don't worry about saving insurance companies money. That's not what you're here for. You're here to make sure that you practice proper medicine. And part of us practicing proper medicine is that we utilize our subspecialists. If you don't utilize them, they're going to go broke and we won't have them. You know, but there's enough disease out there that they'll be used, you know, quite frequently. So don't worry about that. Okay. So put it into their hands. Let them follow the bowed legs. You're going to have a lot of mothers that are going to be worried about kids that have flat feet. Well, there ain't a whole heck of a lot you can do about that other than give them arch supports. Okay, you've got to explain that to them. You know, and most kids have flat feet. I don't know if you remember when you did pediatrics or not, but if you see the little kid, he's running around on the floor without their shoes on, their little feet are as flat as, you know, it's all get outs. They don't develop their arches till later on. Okay, so that's a big one. Now, we're going to get to probably the most important thing of pediatric orthopedics is to check their hips. You can have motion. You hear my fingers clicking? You can have motion and clicking in any joint in the body except the hip in the baby. That's a big no-no. Any hip clicking motion, excessive motion, it just doesn't feel right, or it doesn't look right, okay? Or their little heels don't line up. You send them to an orthopedist and let them follow them. You don't want that burden on your hands, because a missed acetabular dysplasia for you, number one, is a nightmare for the child, because every time they need to have growth of the femoral head, they're going to have surgery with implantation of bone. Could you imagine a nightmare like that? Okay, and guess who would be responsible? You're right, Lauren. We would be the responsible party, and you don't want to be the responsible party. Okay? So that's one of those things in ortho that you are very, very careful about. Okay, let me think of some. Now, other diseases would be things that stand out big time. You would know certain things. Kids aren't growing. That would be more endocrine than anything, when they were just not growing on the growth curve and so forth. But, you know, if their legs are bowed, they may be a little shorter too. Again, refer those kids to the ortho folks and let them handle it. Okay. All right. See, so orthopedics, that should be that. So let's talk about asthma. Okay. Do all of y'all feel very proficient in asthma? I see some heads moving back side. I see this. Okay. Well, that's the way you should be at your stage of the game. Because asthma is like, I remember one of my attendings told me that asthma is like a tiger. As soon as you turn your back on asthma, it will eat you alive. So be very conscious and very careful about asthma. Okay, I had a little kid. His name was, I'll never forget him as long as I live. His name was Hercules, a little Haitian boy. And he died last year. He died because of a bad parent. The kid had been admitted to Arnold Palmer's ICU twice for exacerbations of his chronic disease. The mother never even went to the pulmonologist for follow-up. And then little Mr. Hercules, the third time, he was 6 years old. The third time around was the fatal time. It took him out. Now, had I known about that, I would have turned her butt into DCF, Department of Children and Family. And believe me, to protect you protect the child and protect yourself too, don't ever hesitate to use Department of Children and Families. They will go out and they'll breathe fire up a part of their body they don't want to be breathed up against. Okay? They will go out there and tell them, look, if you don't go to the doctor, number one, you're going to lose the kid. And number two, you're going to lose your Medicaid benefits. And that stimulates a lot of people to move. And we hate to think of people as being that way, but unfortunately, when you talk dollars to people, and that's their livelihood, it's a nightmare. I mean, we hopefully are reasonable people, and a lot of you young ladies are going to have babies, and I hope you have a lot of babies, and enjoy your babies. You would give your life for your baby, right? I see a lot of heads nodding. And it wouldn't matter to you. You would give your life for your child and not think twice. But there are people out there that don't think like that. I even had several of this Munchausen stuff. You heard of that before? I've had 2 or 3 of those over the years too. And I was convinced, I had the cops go in and swoop and pick up a kid one time because I was absolutely convinced that the mother was going to kill the baby. And then a judge gave the baby back to the mother and they left the state. I never knew what happened to that kid. I just said a prayer for him, and they left the state on purpose. Because back at that time, there was no interstate watching of mothers like that. So you'll have sicko people that don't take care of their babies. I'm sorry, but we got to be the guardian ad litem there. And we got to step in and we got to make sure that these kids are taken care of. You call DCF on them and they will be on them. There's some slack ones. Sometimes I've been a little disappointed in DCF over the years, but in general, they will go in and take care of those kids. And if they see there's a danger, they'll swoop them up and they'll put them in foster care. And that's the best thing we can do for the child, is to swoop them up, put them in foster care. The parent loses their Medicaid benefits, and boy, they get their act together real quick. They quit doing drugs, they go to drug rehab, and because they know they're either going to lose their kid or benefits or both. Okay, and we hate to be that way, but you got to smack people sometimes to get their attention. We can't do the smacking even though we feel like doing it, right? But we'll go to jail for that. But the DCF can come in there and smack them in a different way. Smack them in the pocket where it hurts. Okay. Okay. So how did I get? See, what was I talking about before that? Help me here, folks. What was I talking about before that?
Asthma.
Huh?
Asthma.
Oh, asthma. Okay, that was Mr. Hercules. Okay. So asthma is divided. You can just think of asthma. I like to think of asthma in a very simple fashion. Asthma, it's either infrequent or episodic, or it happens all the time. And there are 3 types of asthma that happen all the time: mild, moderate, and severe, persistent asthma. Now that means, when you use the word persistent asthma, that means disease. The airway is swollen. Disease, it doesn't go away. It doesn't go away because you want it to go away. Okay, with the episodic asthma, which is the intermittent asthma or the exercise-induced asthma, that's not disease. That's a disorder. And the difference in the two is that with the exercise-induced or the intermittent asthma, there's no airway swelling. So you don't need steroids. is just a spasm of the airway, the smooth muscle spasms. So when people, when kids go out there and they're on the track field, when they're running their track, they're fine, and it doesn't affect them till they finish. And when they sit down and they're having a hard time breathing after they've done their exercise, that's exercise-induced asthma. It's smooth muscle contraction, right? And you could use a short-acting bronchodilator for that. Use your albuterol inhalers. And that usually takes care of that. Now, what would it tell you if a kid or teenager was running, and when they finish running, what they'll tell you to do is give 2 puffs 30 minutes prior to exercise, and it will help you to not have that exercise-induced asthma after you finish running. What happens if you gave the 2 puffs prior, the kid runs, and then at the end is wheezing? What does that tell you? What it tells you is we're not dealing with the intermittent or exercise-induced asthma. This kid's got more than that going on. This kid has airway swelling, which is mild, moderate, or persistent asthma. Okay? So therefore, you need to reevaluate that now. We're in the wrong category. Okay? Your asthmatic patients, as you see them, you're constantly reevaluating these levels of acuity. Okay? You got to keep going up and down, finding out where are we at on the spectrum. Because you may move from this to this, or from this to this, or this to this, or this to this. That's where the specialists come in. Again, don't get yourself caught with your britches down. You do what you got to do. These kids that don't respond to the treatment that you're using means that they are on the wrong medications, or they're not diagnosed properly. I'm not blaming you for not diagnosing them properly. I'm just telling you that their asthma changes. You know, you're born with asthma, you die with it. Whether it flares up on you in the process, that's a different ballgame. Okay? So we got the exercise-induced kid that we were controlling with ProAir, or there are three available commercially, and you got to remember their colors, because that's what you're going to need to refill. The blue-gray is Ventolin. The orange-yellow is Proventil, and the red-white is ProAir. So you want to put them on the same one they had before, because that tells you that that's the one their insurance pays for. Because if you don't start them on the same one, you give them one their insurance pays for, what good did you do them when the parent doesn't have a nickel to, much less to $50? Okay? Am I understood? Okay? So let me get some drink here real quick. All right, so let's say we got a kid. Let's say you inherited a kid in the office from Dr. Jones down the street, and the mother says, oh, well, he's asthmatic. Okay. So there's a way of telling what the doctor prior to you thought the kid had. Whether they did a pulmonary function test or not, you can at least know what the other doctor was thinking. That doesn't mean it's right or that we could stop there, but at least you'll know what you're thinking. By mild, moderate, severe asthma, most of them are the medicines are graduated. Flovent is 44, 110, 220, right? So you can tell what that other physician was thinking. 44, 110, 220, mild, moderate, severe. At least that's what the other guy was thinking, or gal. All righty? Okay, so a lot of them are 40, 90, 180. Pulmicort, the inhalers. 40, I think it's 45, 90, 180. Then you have one called QVAR, 40, 90, 180, if I'm not mistaken. So you'll always see that change, right? And you'll know, okay, this doctor thought this person had moderate persistent asthma. And when you say persistent, the reason for the persistent is that the airway is swollen. So let's just make this up for a second. This is a normal open airway. This is a mildly swollen airway. This is a moderately swollen airway. And this is a severely swollen airway, right? Now, what kind of an airway would you, if you're asthmatic, would you want to have? You want to have one that's the least amount of swelling that you could possibly have. And that's where, when people use their inhalers on a daily basis, they keep the airway unswollen. Because when you have airway swelling, let's say you have moderate swelling, and then all of a sudden now you're going to throw in their spasm. You've got a moderately swollen airway that spasms and is not really allowing much air to run through it. So you can get in trouble real quick. So how can you always make sure that your patient is properly diagnosed? And as their asthma changes, that you stay on top of the asthma that changes. How do you do that, is the question. Anybody got any thoughts?
Pulmonary function test.
Oh, I'm sorry. Go ahead, Kay.
Oh, sorry, a pulmonary function test.
Exactly. Exactly. You either do them in your office yourself, which I don't particularly care to do, because whenever you do those types of tests, you assume the liability of being a pulmonologist. And I've seen cases, remember now, I've seen 30 years of cases, and I've seen everything. You ain't nothing I haven't seen. Murder. Can you imagine that? Doctor takes out a policy on his partner and solicits murder. So I've seen everything medical, legally in 30 years. That they would not surprise me. So when your kids have asthma, you've got to stay one step ahead of the asthma to be proficient. And the way you do that is by you making sure that this kid gets a pulmonary function test. And then that will define the asthma. It will tell you this, or this. If you're going to have somebody that's got persistent asthma, send them to a pulmonologist so you get a baseline. That's what you need. You need a baseline. And then the pulmonologist will do, depending on what baseline they find, either mild, moderate, or severe, they will get them back and do another pulmonary function test 6 months later. Okay? There's your buffer. How many times do you think I've seen people who have asthma and they don't do their follow-ups, and then there's a bad outcome? Not just my patients. Remember, I review other people's patients too. A whole hell of a lot. More than I would ever want to think. And all these children could have been saved. Now, if you are, let me warn you of one thing though, and I've seen this too. When pulmonologists, when doctors' practices, especially family practices, like to do pulmonary function tests, when they get a bad outcome one day and somebody dies, pulmonologists will actually go in court on the plaintiff's side and testify that had this child been seen by a pulmonologist all this time, that the kid would have been alive. So you got to be careful about that, because subspecialists protect their areas, and they'll go after you if they think you've gone outside of your area of expertise, and they'll testify against you, and more than likely you'll go down the tubes. Okay? Understood? Capiche, right? So that is something that is extremely important. That's my father-in-law. Hey, phone. Yo tengo clase aquí. Okay, so remember when you do those, you have those 3 different categories. See, as you go up in the categories, you're going to go up in the strength of the steroid, and the from a short-acting bronchodilator to a longer-acting bronchodilator, and from a low-potency steroid to a higher potency steroid to a higher potency steroid. You'll see that in Advair. They have different levels, right? You'll see that in Pulmicort, different levels of intensity. I would never, ever, ever, please do not treat severe asthmatics. That's the category where they throw the book at them and the kitchen sink, because that means you give every single medicine you can possibly give to these people, and then they still die. They'll drive down the road and there's a little perfume that comes through the window of the car and they have a horrible asthma attack. So you need to let those people be taken care of by the pulmonology people, either adult, if you're going to do family practice, adult or kids, same thing, doesn't matter. I see I got a couple of people here I hadn't seen. Felicia, hello Felicia. Angela, oh hey Angela, how you doing, kid? Kayla, Laura. Okay, so that's extremely important. Is this coming across to you? Because sometimes I don't know if I'm coming across or not. Is it coming across okay? Okay, so it's extremely important to make sure that you're on the right page with the asthma. And the way to do that, let the experts do it. Okay? Because I've seen, again, when I review the charts, I've seen so many times that people go and they'll just lie through their rears and say that the doctor never told them to come back. And you know that's not true. The kid has moderate severe asthma, moderate persistent asthma, and then they're saying don't ever come back. Yeah, right. Okay, so you need to have that buffer. You didn't do that. That's a specialist. That's they're going to fight it because they make these people sign statements. They make them view videos of asthmatic children and what you got to do. And they do follow-up phone calls, and the people don't respond. Then that's their problem. It's not your problem. We don't want the child to suffer, but we can only do the best we can. And I have turned them into DCF when I found out they're not going back to the specialist. I'm sorry. I don't want to have a dead kid on my. If I had only known that Percules' mother had not sent him for follow-up, I'd have turned her butt in a damn heartbeat. But I didn't know. So unfortunately for the little boy, all you needed was a decent parent. And I think she's a druggie anyway, because I remember this day and age is kind of commonplace. You go in a room and you smell marijuana. Or what I think is marijuana. It has a weird smell to it, so it must be some form of marijuana. I don't know. And it doesn't go away. The smell is there. The whole room stinks, and when they leave the room, it still stinks, So, anywho. All right, what's left here now? What are we going to say here? We talked about asthma. Do y'all feel a little more comfortable about asthma now? A little bit? Teeny bit? Okay. Surgical issues. All right. Probably the biggest things that you're going to have surgically. Oh, we left out in urology, undescended testicles. Okay, and little babies, their testicles feel like. You ever gone to a farmer's market and felt what a pea feels like? It's hard. It's not soft. So a little boy, little infant, small boys, just up to a few years of age, their testicles are going to be hard like an uncooked pea. Okay? If it's soft, it's probably not a testicle. It's probably some blood vessels that have squished up and into an area and feel like it, but they're not. So don't let that fool you. Okay? And any type of an undescended testicle, you refer them to either a pediatric surgeon or you refer them to a pediatric urologist and let them follow the kid. I can't tell you how many times I've seen this, where there's no follow-up and then the testicle ends up being destroyed. And then the parents file a lawsuit against the practitioner. Oh, he never told us to come back. All right, can you see that one coming? But if you refer them to the pediatric surgeons or the urologist, they're going to tell them to come back in 6 months, and we're going to do another ultrasound. Because on the ultrasound, they can tell viability. They can see the, the circulation on the ultrasound. And if there's some type of issue with viability, they'll go ahead and do surgery and pull them down, right, to protect the child. Okay? I'm going to tell you a funny story. Dante, big hush. Hush. That's our rescue dog. He's missing a leg. I just took a lipoma off his leg last week. I couldn't find a veterinarian that would do it, so I did it myself. And he's doing good. He walks around on his leg. Good boy. What you want? Excuse me 1 second, guys. I got to go open the door so Dante can go outside and take a leak, okay? Hold on 1 second. Come on. Come on. Come on. So anyway, this is kind of a crazy story, but this will get your attention if you're falling asleep. I got a letter from a pediatric urologist here locally. I won't say his name, but he's always joking. Okay, and so I got this. I had sent a kid to him because this kid came to me, and I inherited the child from somewhere, and the kid didn't have any testicles. And he's let's say around 10 years of age. And I was really worried about him because, see, if they sit in the abdomen that long in the heat of the abdomen, they'll cook. They get destroyed. And so they're no longer viable. And you'll have to have a child that would end up needing testosterone. Of course, they would become sterile. They wouldn't have children. And then they would need testosterone injections. Okay? Willie came over to say, hey, Willie. Hey, Willie. Got a bunch of female dogs around here. They all fight with each other. Y'all don't fight with each other, do you? Girls, right? No, I didn't think so. Okay, so he sent me this letter, and he said this child suffers from something called Vanishing Testicular Syndrome. What? It's Vanishing Testicular Syndrome. I never heard some crazy thing like that in my whole life. Here I've done pediatrics, I've done a year of ER, and I said, I've never heard some baloney like that. And I thought he was just pulling my leg, you know? So I called him up and I said, what the hell is this Vanishing Testicular Syndrome stuff? What hat did you pull that one out of? And he said, no, it's real. He said, sometimes the body will turn on the antigen of the testicle and consume. You ever heard, when people have their veins obliterated by chemicals, or they do the vein ablations with the lasers, the body reabsorbs the dead tissue and the vein disappears. I mean, it'll disappear and there's no trace of the vein left, no scars, no nothing. That's what happened to this one boy. He had lost them because of an immune response in his body where his own immune system had attacked the tissue and it had consumed the tissue. And I'd never heard of that before. I thought that was the craziest thing I ever heard of, but it was true. He said it's rare, but true. So I learned something here a couple of years ago that I had never known. And remember what we are practitioners, and we're constantly learning new things, right? So don't ever think you can't learn new things, because you can, all right? Okay, let's see here. What else do I need to tell you guys? What rami are left over that I haven't talked about? Oh, gastroenterology. Oh, pediatric surgery, appendicitis. Appendicitis is something that is very, very important. Any questions? What's McBurney's line between the belly button and the right lower pelvis? Anything in that area there, you could be very suspicious of, refer them for ultrasound. Pediatric surgeons like ultrasounds, ER docs like CT. So you get that little clashing of opinions there. But you know, you can, if you're in an office setting, you want to do a quick CT ultrasound, that should give you the answer too, because you know that you would see a swollen appendix, hopefully. Now, I have seen left-sided pain with appendicitis because the appendix, the colon was a little weird, and the appendix actually drooped over onto the left side of the abdomen, and that kid had left-sided abdominal pain. So just because it's not right-sided, don't think that you can't have appendicitis, okay? Because you can. Most of the time, let's see here, with pediatric surgery, you're going to be having cysts taken out, lipomas. If lipomas sit too long, they will get infected. So that's why I like to get them removed. Okay? Skin lesions in children, kids will get melanoma. They get melanomatous lesions that aren't active, they're sort of dormant. When I see children with these types of skin lesions, I send them to the dermatologist and ask them to be removed. Okay? Because I don't, you know, eventually these things are going to change. They're going to become malignant one day, and I don't want them to get malignant and the kid didn't pick up on it, and then it kills them. So when you get kids that have a lot of melanomatous looking lesions, get rid of them. Okay. Occasionally we see vitiligo. Don't see too much of it, but you do see it. You see a hell of a lot of eczema. Okay. My and William and Emily, you know, they saw that in my office. You see kids Andrew, you see that stuff all the time. Angela, you see it all the time. So you can pick and choose what you like to treat with. I use something called fluocinolone oil, which is an oil with cortisone in it. You can just use paste. You can get the pharmacy to make you a triamcinolone paste. You can gush that on, you know, and so forth, and get it made in jars and so forth, you know. And the dermatologists a lot of times will make up their own concoctions, you know. The only thing about it, sometimes when you refer to dermatologists, the issue could be that they will give medications that are not paid for by Medicaid. And if they're not paid for by Medicaid, then what happens is the individual ends up not getting medication. Okay? And you don't want to do that. Remember, be careful about writing brand names, because brand names a lot of times don't get filled. And the individual may be a little embarrassed to come back to you and tell you they don't have the money to buy the medicine, and then the kid doesn't get treated. Okay? So let's talk about gastro stuff. Probably the biggest gastro problem we see is feeding problems in little babies, reflux, and pyloric stenosis, okay, and constipation. So there are different ways of dealing with this. You go to different practitioners. They all got their own little remedies, okay? Most of the time you'll deal with lactose-based formulas, and when those don't work, you can go to soy-based formulas, because there's a program called the WIC program, Women, Infant, and Children, and they get free formula. So, but they have rules that you're supposed to follow. So you go from that to soy, and from soy you can also go to other ones that they've watered down the proteins a little bit, I guess is one way of saying it, so they don't have such a reaction and they don't throw this stuff all over the place. Because you have kids that they'll eat whatever, and then bam, it comes right out and it goes everywhere. Now, those kind of kids, you kind of worry about pyloric stenosis, which tends to occur around a month of age. So be careful about that. Send them to the gastro people the same day or the day after, and they'll get an ultrasound done real quick and make sure they don't have pyloric stenosis. And then that's fixed surgically. They go in and just kind of slice the nerve endings right at the pylorus, and it goes away, and they're fine. It's a one-day procedure. They're gone and they're home. There are specialty formulas. One of them is called Nutramigen, and Nutramigen is, and then Alimentum. They're both hydrolyzed. In other words, they go into where you have multiple carbon bonds, and they break those carbon bonds. And I think they use some type of electrolysis to break these bonds, so that instead of the body having to break the bonds down slowly, these bonds are already broken and you just have to absorb them. And that's called nutramigen. That's really, and they take the milk protein out of the nutramigen. So you're not dealing with milk, you're dealing with non-milk protein, broken down carbon bonds, triple bonds, quadruple bonds, whatever the hell it may be. It's broken down already for you so that all you have to do is absorb it. Okay. And that works really good. It usually when we get stuck in a corner and we don't know what to do, and there's not much science to this. This is mostly just trial and error, that it works really good. It really does. Pyloric stenosis, you'll probably see it about once every 4 or 5 years, so it's not that common, okay? Mostly it's the feeding issues. Constipation, we see it all the time, especially in breastfed moms, because they're not giving volumes of fluid to the kid. They're giving more concentrated formula in smaller volumes, so they tend to get dry in the rectal area, and they don't go to the bathroom every day. So what you could do is, you can give apple juice, prune, anything that has sorbitol. As it goes through the intestine, it sucks water into the intestine. So as it goes through, it pulls water into the intestine, and it helps you have more water in the sigmoid colon, and you go to the bathroom. Kids go to the bathroom. You could use apple juice, prune juice, or grape juice. They all have sorbitol, or they're supposed to. Now, if they don't have sorbitol in it, you're wasting your time. So tell the mother to look on the back of the label, whatever they buy at the store, and make sure that they see that word sorbitol, because if they don't have it, then it's not going to make a big deal. Now, I tell people there's a little remedy that I use sometimes, where you get dried prunes and you mix it with half and half cream, and you put it in a blender, and it makes like a puree. If you need to put a little ice in it for a kid to make a Slurpee, you can make a Slurpee, and then that prune, everybody knows that if you take a prune, you'll go to the bathroom, right? Well, they're quarter, huh? So anyway, as it goes through the intestine, it sucks the water in too, okay? And that in itself will help the children to go to the bathroom, okay? Most of the other issues gastro-wise, you don't see them. You won't. Just make sure that when you're checking out a gastro kid, that you evaluate the abdomen very carefully and do it in a sequential manner. In other words, start down at the lower level towards the pelvis and work your way up. Push as far back as you can to try to reach the retroperitoneum, which is very difficult, by the way. It's not an easy task. And you make sure that you don't feel anything in there that shouldn't be there. I've felt enlarged spleens, enlarged livers, and tumors over my 30 years. I felt hepatoblastoma maybe about 4 or 5 years ago. I felt a benign tumor of the abdomen not that long ago. And I felt splenomegaly quite a few times. I even had a spleen that was so large that it covered the entire left side of the abdomen. It ended up being Epstein-Barr virus. I thought it was some kind of horrific lymphoma and that this kid was done deal. When you feel something that large in the abdomen, it scares the fool out of you because you think it's a cancer of some sort. But it turned out to be, it wasn't a cancer. So thank God for that. All right, now what are the sciences that we've not talked about? Tell me a science we haven't talked about. We talked about ortho. What's left, guys? Help me out here.
Infectious disease.
Infectious disease. There you go.
Dr. Caron, did we do neurology?
Which one? Which one?
Neurology?
No, not neurology. So we'll do those two. Neurology. Most of what you see in neurology with children will be developmental delay. That's your number one diagnostic issue. Then you'll see number two would be behavioral problems, like, unruly, violent, even kids, anger issues, things of this sort. And then the next one would be epilepsy. Okay. With the developmentally delayed children, you would send them in for a psychological evaluation or a neurological evaluation if you thought it was neurological in origin. you've got to kind of remember, if you're dealing with more behavioral stuff, you probably need to go psychology first and get a psychological evaluation. If you think it's organic in origin, you're going to want to go to neurology. We see autism, in kids, and autism itself, I think it's overdiagnosed. It's like ADHD at the very beginning. Everybody had ADHD 20 years ago. I think that probably the incidence of it being diagnosed now is a little less than it was way back then, because everybody got diagnosed with ADHD before. Now it's autism. If your kid is slow in school and acts a little weird, well, he's autistic. And I see kids in the office that have been diagnosed already with autism, either by a neurologist or a practitioner, and I don't think they have autism. They come in, they communicate with me, they play, they want to be hugged, they want to be loved. Maybe they're a little weird. That's okay. Half of us are kind of weird anyway, aren't we? Here I'm talking to a screen with a bunch of people there, Probably 20 years ago, 30 years ago, they would have thought this was weird, So what is weird? I don't know. But the kids, I think that you have to be careful about putting labels on people. Oh, by the way, asthma, putting a label on asthma may keep them out of the military. So be careful when you diagnose people with asthma, because if they come back when they're 20 years of age and they want to go join the military, if the military sees that they've had a history of asthma, they won't take them. So be careful. Make sure it's really asthma. That's why I'm saying go to a pulmonologist. But anyway, neurology-wise, you'll have a lot of you'll have frequently febrile seizures. You don't treat those, unless they become a sequence, unless they become more than one, where somebody's having febrile illnesses, and then they start to decide, well, it's easier to treat these kids than not to. It gives you better control. Autism itself, sometimes you see these things early and sometimes you don't. Sometimes they show up later. I have a kid, he's about 26 years old, he's autistic. He is about 6'7" and weighs around 350 pounds. And his mother controls him very, very well. Oh, I just lost my screen here. How do I get that back?
What's the problem?
No, the screen disappeared. Now it just says Zoom.
Oh, check your taskbar at the bottom. You might just be able to click on the Zoom icon and bring it back up.
There we go. Thank you.
Okay. All right, no problem.
Oh, I see Emily Saldana. I didn't see you before. How you doing, kid? You remember I see you guys in masks. So when I see your face, sometimes you surprise me. Because everybody and then it's the same thing. I keep seeing masks on people. That's all I see is this right here every day. Yeah, the autistic child, it's an interesting diagnosis, because you can read books and then you'll see a kid in the office that's been diagnosed with autism, and then they used a totally different criteria for diagnosing them, and they didn't really meet the standard criteria for autism. Used to be most of the autistic kids were sort of lived in their own little world. They didn't communicate with the outside world, and they tended to stay there. Then you have a spectrum, an autistic spectrum, which is where most of the kids fall in, where they're at different levels of different levels of communication with the outside world. Now, I will say a lot of times these kids are very belligerent. And that's one of the early signs of autism in a child, is the kids that are belligerent and they're fighters. They fight with their parents about everything. Anything and everything upsets them. They have a sort of I guess we call it a short fuse, where things set them off and it doesn't take much to set them off. Usually it's the inability to communicate with us as human beings is your key diagnostic criteria. And again, you can review I don't know if we have time to go through the whole autistic spectrum review, but look at Autistic Spectrum. And then that gives you from A to Z what you could possibly see as different symptoms. Okay? This is for Liz, especially if you're interested in neurology. Alrighty? Most neurological diseases you don't see very often. They're very infrequent. Mostly it's mentally retarded children. Delayed children is a better way of putting it. And you can help these kids with therapies. And even the autistic children too, they give them speech therapy, occupational therapy, they give them developmental therapy, and it works quite well. It really does. Sometimes you don't think of therapy as being a modality that would give you much return, but it does. It really does. You'll be very surprised how they'll improve. They'll improve in school. They'll actually make normal grades. You know, they'll be a little kind of strange compared to other children, but they can function very well. They really can. True epilepsy needs to be diagnosed, and don't ever treat those kids yourself. Let them be treated by a neurologist, okay? Because the medications are complex and a lot of toxicity to the medications. You don't want to have people that get into trouble with toxicity, liver toxicity, and all that kind of stuff. Okay? I got 12 minutes. All right. So we'll do some infectious disease here. As you've all seen, we're dealing with a virus that is an atypical virus. This COVID-19 stuff is a little on the atypical side. Most viruses tend to die out in the warm weather. By the time the warm weather, you know, we get winter viruses that tend to dissipate and die when the sun hits them. As the weather gets older, you lose your winter flus, right? You don't tend to have as heavy a summer flu as you do a winter flu. This COVID-19 is sort of done its own thing. It's a different bird, and we're just going to have to deal with it and I do think the social distancing and the masking helps. There's a lot of exposure to the cases, probably more than we think, because you see the numbers are going, the more people you test, the more people are positive. Now that's not necessarily a bad thing because you develop herd immunity, right? And that's what we need right now. We need herd immunity because we don't have a vaccine. I personally have treated a whole bunch of people with hydroxychloroquine, and I got 100% cure rate. 100%. And I even treated some of my friends and family, and they were sick. So I went a little bit off label there. But I personally think that they jumped to conclusion because in Europe, they had very good success with hydroxychloroquine. In Spain and France and Germany, England, Italy, hydroxychloroquine the key is you got to catch it early. It's not one of those medicines you can use later on when they're in the ICU. I think remdesivir is better and for the later on cases, because that's where they've done their research on ICU people, and then by the time they hit the ICU, they're on a ventilator, right? Anti-inflammatories, leukotriene inhibitors have been big time because it seems as though the virus causes pulmonary edema. The virus doesn't kill you, it's the pulmonary edema and the DIC that it triggers. Did y'all hear about the DIC stuff? Y'all heard about that? Yeah, it seems as though it creates this DIC issue. And so I had some friends of mine, they were really sick. And I started them on hydroxychloroquine, I gave them the Z-Pak, I gave them the zinc, and I put them on aspirin for the DIC stuff. I gave them a ventilator, we used albuterol, and we used prednisone. Now, they're coming out now saying that it's better to use budesonide than oral prednisone. But at the time, that was the recommendation, was the oral prednisone. But I did give them a steroid, and they did get better. And they're done now. It's over with. I took the hydroxychloroquine myself as a prophylactic, and I did fine. I think they say, I gave it to my wife too because she sort of got sick with it, and I didn't test her, but she had all the symptoms, and I treated her with it. The only thing she had was GI complaints, It gives you diarrhea and stomach cramps. So we just sort of suffered with it. And my two other friends that I gave it to not too long ago, they both got stomach cramps and diarrhea. And we just dealt with the diarrhea by doing a lot of, drinking of salty stuff. Infectious diseases is a wonderful topic. Beside the viral illnesses that we see come and go, the bacterial illnesses seem to be something that we struggle with, right, at best. I will say this, be frequent with doing CBCs with your kids that come in your offices and have fevers. Make sure, because you don't know who is bacteremic and who is not. Okay? Now, remember how bacteria are categorized. You initially have a focus of infection. If that's untreated, it goes to bacteremia. If that's untreated, it goes to septicemia. And then if that's untreated, it goes to meningitis, because it breaks the blood-brain barrier. Our job is to kill it when it's at that level of the focus of infection, right? Ears, throat, lungs, urine, skin. And in children, I forgot to say something about your urine. The medicine for Central Florida for urinary tract infections in kids is cephalexin. That's the recommendation because of the epidemiological studies that have done here locally. And the other thing with skin is if you want to cover 98.5% of the skin germs that could affect a human being, adult or child, you give a combination of cephalexin and clindamycin. And nobody can criticize you. Now, you give cephalexin and you miss the MRSA, they could criticize you. So just go ahead and use both. That's what I do. And they all go away. That's not going to cover everything. It won't cover Pseudomonas, and it won't cover Enterococcus. For your own edification, read about Enterococcus. Okay? It's a weird germ. There's no real therapy for Enterococcus, which is scary. You go into the hospital I had a kid that had Enterococcus skin disease, the worst, looked like smallpox. And this kid, they just put this kid on like 6 antibiotics. And this was the infectious disease people at New Moors. And the kid did respond. So they think that there's a synergy between an aminoglycoside and something else, maybe. It's a maybe kind of a thing. So for your own edification, read about Enterococcus, because it's an enigma in medicine, and it's a dilemma. Okay? But if you go with cephalexin and not Cipro, the other one, clindamycin, you should be okay. 95% of the time, 98% of the time plus. Remember now, when you're dealing with the focus of infection, that's our job, to keep it at focus and not let it spread to bacteremia. Okay? And be honest with your diagnosing. Don't treat when you don't need to treat with antibiotics, because you're better off letting it go. You'll catch it later. People don't die in one day unless they happen to have hemorrhagic strains of bacteria like MRSA. Okay? You have plenty of time to catch up with this. Bacteria usually would take you 4 or 5 days to die. So if you don't see a focus of an infection, please don't treat, because you will get caught when they hit the ICU and there's no focus of infection. They're going to go back and look at your chart and see that you said there was a focus of infection, but there wasn't. And then that's considered inappropriate administration of antibiotics. Okay, that could be loss of licensure. Okay, all you gotta do is just be honest. And don't let parents force you into giving them an antibiotic when it's not necessary. Again, I promise you, you've got plenty of time. You do a CBC, you do a blood culture, you will look at the results, and you'll be able to pick up on it. Because what's going to happen to a kid that had early bacteremia? Well, they're going to get worse. They're going to get they're going to get more fevers. They're going to start vomiting. They're going to start looking like crap. And the mother's going to either call you in panic, or they're going to take them to the ER. And you've still got time to save the child if they're bacteremic. They've not become septic yet. Because the immune system is fighting this, right? When you're bacteremic, your immune system is attacking like crazy. White blood cells and antibodies are attacking to try to control it. May not be enough to control it, but then that's where you're going to pick in. You're going to pick it up before it goes into septicemia and or meningitis. So the safest thing to do, maybe see them back the next day. Do a CBC with diff and see them back the next day. And be frequent with your administration. I mean, your prescribing these different labs. Okay. Do a lot of labs. Whoever's been with me in my office rotating, they know that I write a lot of labs. And that's one way of protecting the patient and protecting yourself. And as a practitioner, that's what you got to do. It does you no good to be sued out of business. You're going to have a 40-year plus career if you want to. You're going to save a ton of people's lives. You're going to save a lot of people from suffering too. And that's a good feeling. You guys got a lot of, you're going to have some scary days. And if you ever need me, you call me and I'll help you. If you need some advice about something, call me and I'll try to do the best I can. And I have people call me all the time. So I don't mind that at all. I'd much rather you ask a question that you don't know. And I did that over the years. I would call specialists that I'd made friends of, and I would get answers, to things that I wasn't sure of. I wasn't too proud to ask a question. Okay. So remember, it's our job to catch it in the focus of infection and keep it there and get rid of it while it's there. If it goes on, if it starts to spread, well, there's other things we can do. We can admit them to a hospital. We can put them in for a 24-hour admission, 23-hour admission. You can always do that if you're not careful. If you're not sure about a child. Nobody will complain about a 23-hour admission. That's an observation. Insurance company won't complain and a hospital won't complain. So we're not expected to be perfect as practitioners. We're expected to be competent, right? Okay? So competence doesn't mean perfection. You can strive for perfection, but we'll never meet that because, there's no such thing as perfection. We're going to try to do the absolute best we can and give everybody the best medicine offers. Okay, so I think our time is up now. I hope you learned something. Hope I didn't bore you too much. And the dog is barking his brains out there. Now he wants to come back in there. So he makes me open the door.